Thank you, Gavin, and thank you for the organisers for the opportunity to speak. We're going to change tack here a little bit. I'm going to talk a little bit more about the surgical aspects of myopia, in particular myopic traction maculopathy and macular holes. Here are my financial disclosures. So the term myopic traction maculopathy comes from Panazzo Giacomo almost 20 years ago, and it's defined as features of myopic macular damage caused by traction. There are four main aspects of this, what we call simple myopic foveoschisis on the left, the combination of myopic foveoschisis with an epiretinal membrane or lamellar macular hole, a myopic macular detachment, and myopic macular holes. Of patients who have posterior staphylomas, about 1/3 of these will have simple myopic foveoschisis, and almost 10% will have myopic macular detachments. Let's look at the pathogenesis of this condition. So there are different forces involved. Firstly, we have antero-posterior traction coming from the vitreous, but also from a posterior staphyloma if it's at the macula. There's also tangential traction from any epiretinal membrane, and there are some hypotheses that there is increased retinal vascular stiffness as well. Barbara Parolini from Italy has helped us understand the pathogenesis and the classification of these conditions. And we can look at it in two different axes. Firstly, the perpendicular evolution from macular foveoschisis up onto a macular detachment, and on the tangential axis in progression towards a full thickness macular hole. And we can combine these two to give the full spectrum of the disease. One of the most important questions is when should we operate? And this is one of the largest studies from Japan. This is from Shimada and colleagues. And they looked at 207 eyes with myopic traction maculopathy. They found that most of these patients, 84% of these patients, remained stable, but about 12% of those patients progressed. Of those which progressed, those patients who had a greater degree of retinoschisis were more likely to progress over a 3-year period. Here are the risk factors for progression on the left, so the increasing amount of retinoschisis. Foveal detachment is a risk factor for macular hole development, a longer axial length, more severe posterior staphylomas, and an absence of a dome-shaped macula. These are all risk factors for progression. Risk factors for worsening of vision include retinoschisis, the presence of an epiretinal membrane or a thickened posterior hyaloid, and a macular hole. David Goucher from Alain Gaudrick's group did a similar study on a smaller group of patients, 29 eyes over 3 years, with patients with myopic foveoschisis, and they showed a higher rate of progression of almost 2/3 of patients progressing. Half of those patients that progressed did have a premacular structure, either an epiretinal membrane or a thickened posterior hyaloid. So the presence of an ERM or a thickened posterior hyaloid suggests that this may be a patient who is more likely to progress. Of these patients, 1/3 of them developed a macular hole, 2/3 of which had had prior foveal detachment. So this is our current thoughts about when we should operate. For most patients with simple myopic foveoschisis, we probably don't operate on these unless it is progressive. Those which have an associated epiretinal membrane, we might consider operating on them, particularly if they're symptomatic and if they're progressive. And patients with myopic macular detachments or myopic macular holes, we usually will operate on these patients. The next question then is, how should we operate on these patients? So we can relieve the traction either internally with vitrectomy, membrane peeling and gas, or we can relieve it by posterior scleral reinforcement, essentially a macular buckle. And the chair, Gavin Tam, will talk about that in the next talk. If we look at vitrectomy in particular, these are the questions we have. And the first question is, should we peel the internal limiting membrane? Well, this is a a systematic review of all papers that looked at internal limiting membrane peeling for myopic macular traction. They had 9 studies, and they showed that ILM peeling had a greater resolution of the foveoschisis, but interestingly, it did not lead to any greater improvement in visual acuity outcomes. In terms of how should we peel, so traditionally we used to peel all the ILM off the macula, but more recently foveal sparing ILM peeling has become the vogue, predominantly because it's thought to reduce the risk of macular hole development. And you can see here, this is a meta-analysis showing that there was greater visual improvement with less macular hole development when we spared the fovea from the ILM peel. Of course, if there is a macular hole, there's also the question now about whether we should perform an inverted ILM flap. And this is a recent meta-analysis from 2021 showing that there was greater improvements in vision as whether the ILM flap was performed as a covering, that is, that the ILM is just layered over the macular hole, or whether it was inserted or stuffed into the macular hole. And this was seen both for patients who had associated retinal detachment and also those who didn't. In terms of tamponade, I don't think there's any significant evidence to say that one type of tamponade is superior to the others. Personally, I still use SF6 gas for these patients. And posturing remains an ongoing question. So even though we know, I think with most macular holes, posturing probably isn't required for macular holes less than 400 microns, we don't have any specific data in the myopic macular hole arena. I'd like to present this case. So this is a patient who had a vitrectomy for myopic foveoschisis. She's a 62-year-old Chinese female, very high myope, -16 diopters, and she's noticed a 2-year history of declining vision in her left eye. You can see here there is myopic foveal detachment. So here we're going to perform a vitrectomy, but in particular we're going to spare the fovea from the ILM peeling. In these cases I do like to use both Kenacort or triamcinolone as well as ILM blue. And we're peeling here around the fovea. So you'll see that in these myopic patients, the ILM is usually very thin. These are more challenging cases. The eyes are very long, so we often need to use longer instruments. The ILM is often very adherent to the retina and hard to peel off. But here we're intentionally leaving the ILM at the fovea, peeling it towards it in a circular fashion using the cutter to trim the edge of the internal limiting membrane. And at the end of the case, you can see there is this ring or donut shape of ILM that I've peeled, leaving the fovea intact. Scleral depression is performed, a full fluid air exchange is performed, and then in this case, SF6 gas was injected as a tamponade, and the patient asked to posture face down. So here is the result. This is a patient had improved vision from 648 to 609, 1 month post-operatively. If we look at outcomes of patients who undergo vitrectomy surgery for myopic foveoschisis, on average from this study, there was an improvement from 6 on 30 to 6 on 15, and the only independent predictor of post-operative visual acuity was the pre-operative visual acuity. So this is an area that still requires more large, well-structured randomized controlled trials and registry data. But I think at the moment the evidence does support that vitrectomy is useful for the treatment of myopic foveal detachment and myopic full thickness macular holes. Thank you very much.
Aye.